We've covered a range of issues related to workforce well-being on this 7-part portion, Caring for Caregivers series, thanks to Wellbeing Trust. We talked about tools to prevent and now mitigate sources of stress and harm to the workforce during and after the pandemic. One of the key themes has been the importance of organizations and leaders, specifically listening to concerns and doing all that is possible to protect the workforce and prevent them from acquiring infection, now doing all they can to support individuals and their families on all fronts, medically, socially, financially, as the pandemic continues to unfold. A framework for doing many of these things comes today from Dr. Tate Shanafelt, who covers a range of opportunities for organizations to hear, protect, prepare, support, and care for their staff in his JAMA viewpoint on the topic. We're going to chat in a link, but we're going to be covering it in detail today. Dr. Shanafelt is no stranger to this topic. Not only is he a chief wellness officer, associate dean, and professor of medicine at Stanford, he's a longtime thought leader and researcher in the field of well-being and its implications for quality of care. In fact, 2 of his co-authored books I keep on my desk at all times. One is a consensus study, this one here, from the National Academy of Medicine, and the other he authored with an IHI senior fellow, Steve Swenson. It's called Mayo Clinic Strategies to Reduce Burnout. We love this book so much, you can tell it's dog-eared and flagged a bunch. We gave it to every team that enrolled in our Joy and Work Results-oriented network. Really, really helpful tools in both of these. We'll share links to them. A fun part of his bio as well is that in 2018, Tate was named by Time Magazine one of the 50 most influential people in healthcare, which is very cool. We're grateful to have you here with us today, Dr. Shanafelt.
Thanks for having me.
We're also joined by Dr. Don Berwick. He's our regular anchor on the series. You likely know him well. He's former administrator for CMS and president emeritus of IHI. Thank you, Don.
Nice to be here, Jessica. Thank you.
So I'll actually start with you, Don, if you don't mind. I'm wondering, as we've talked about this a lot, of all the anxieties that the workforce is facing today, exposure to infection, access to childcare and other family needs as kids have gone back to school, work demands, financial concerns. What are you hearing the most, and why do you think that is?
Well, on the good side, I'm hearing repeatedly from both leaders and workforce that there's a deeply meaningful experience underway. The way that the healthcare workforce has rallied to deal with this ongoing and dreadful pandemic. So that as clinicians, I think there's a sense of, even pride, something very, very deep and positive as professionals. But on the human experiential side, it's very, very, very difficult. You've listed some of the stresses. I hear a lot from young parents, families that have 2 workers, as kids are going back to school one way or another, either virtually or really. The stresses on families are phenomenally large. The stresses fall, of course, unequally on people of disadvantage, people, the lower income people in the healthcare workforce, as well as in society at large. And I hear a ton about that. I spoke to a colleague recently, a person of color, who said she knows 32 people who have died of COVID time since the epidemic began. 32 people on her Facebook network. This is really, really erosive. There's something Tate comment on. I think we're in a kind of second wave of stress. I'm hearing exhaustion now. More and more people saying, how long will this go on? And the initial kind of punch of the stress, which was serious, now has on top of it this chronic, erosive quality that I really resonate with. In fact, I can see it. I can feel it. This is now, it's in a way normalized. It's part of our lives but it's erosive. And I think we're going to need new coping strategies for what I think is going to be a longer haul of this kind of stress. That's some of the background. We haven't even begun to talk about other nations and what's going on in countries less wealthy than the U.S. where economies are afflicted. And that's the last point I'll make is the economic impact. The impact that grips us most is the burden of illness. and a disability, but our economies are taking an increasingly serious hit. A recent study just this week from the Harvard Chan School of Public Health and the Robert Wood Johnson Foundation found that over 50% of families in 4 large American metropolitan areas say they're under serious financial stress now, consequent on the COVID pandemic. So we're still in the middle of it. I have to say, having Tate here, it gives me goosebumps in a way. He literally wrote the book, as you said, about how to deal with stresses long before there was COVID, along with our colleague Steve Swinson. I admire Tate so much, and one of the things that I can't wait to share with you is that he was prescient. That Tate and Steve have been on this case for many, many years, long before COVID hit us, and we are really, really lucky to have him with us today, Jessica, as a person who's really devoted a substantial part of his career now to the very issues that are now reaching a peak in the COVID pandemic.
Yeah, and I'm sure you're not alone. So folks on the line, as I transition to Tate, please feel free to chat in any questions or comments you have for him or for Don or for anyone, and I'll raise them up as I'm able. So with that, I'll actually transition to you, Tate. Thank you again for being here. I'm going to give you 3 questions all at once. I'm wondering if you could walk us through your framework for understanding and addressing anxiety, some of the topics that are anxieties that Don raised. Talk to us a little bit about the process of creating this framework and what, if anything, has changed since you penned it in April. And finally, just some examples of application, either at Stanford or other locations.
Great. Yeah, absolutely. And Jessica, did you want me to use the slides here or just freelance a bit?
Yeah, if you want to just tell us next slide, we can advance for you.
Sounds good. So if you want to just maybe bring up the second one, we can talk about, but maybe while that's coming up, Dawn, I think some of the things you said really resonated with me about this new phase of things that we're in as we have continued to have regular listening sessions with our healthcare workers. There's been a change in the tenor of what folks have shared and been really talking about over the last couple weeks. And I think the pivot, at least that we've seen, is a much more substantive struggle with what's happening in their personal life now. Certainly the chronicity of shelter in place, being disconnected from support networks, dealing with virtual school or the challenges of back to school, struggles, as you said, 2 career families, tension related to the election, tension and concern regarding social justice issues that we're confronting as a society, just so many of these things impacting our people, and that they are really struggling with those things, even as some aspects of the COVID pandemic in the hospitals have improved. And I think, as you said, those challenges are going to be with us for quite a while, and we need to be thinking about how do we support our folks with some of those dynamics. And Jessica, I can't see the slides. I don't know if they're up. Just give me a cue. If other folks can see them, I can go ahead and walk through. But
that's like karaoke for you. Let me see. I don't know how to help you see the slides, but they are up. Right now we're looking at the traditional sources of distress. I can go to the acute.
That's perfect. If you maybe can just, so I'll just speak to that and then I'll just say next slide. So I think, don't need to belabor things here of some of these dimensions of distress that have been with us a long time, some of the chronic occupational distress in healthcare workers. And it's not hard to see the way the pandemic has exacerbated a number of these things, different dimensions of moral distress, just greater challenges integrating personal and professional life, as we've touched on, work demands increased and the like. You can advance one slide to the models slide. I think here what's shown are the National Academy model, our Stanford model, the traditional hierarchy, and I think The point I would just make is that these were developed in a sense for a different time and a different challenge. And our view in the very early days, the first week of the pandemic, was that none of these was the right framework for thinking about what we were dealing with right now. And so if you advance just one, sources of anxiety and fear during COVID, we, in a sense, begin in the first week of March, just saying, you know what, we actually don't know how to respond and support our people with what they're dealing with right now. And so rather than try to repurpose an old playbook, we held these sessions to really say, what are the things that are challenging for you right now? What do you need? And use that to develop the framework on the next slide, as you said, with these 6 components that we really heard consistently from our nursing colleagues, nurse practitioners, PAs, physicians, residents, fellows, our whole workforce around, hear me, protect me, prepare me, support me, care for me, and honor me. And if you go ahead one, I'll just walk through each of these very briefly, and as you said, maybe give a few examples. The hear me dimension, I think, is one of the things, several of these illustrated why Maslow's hierarchy is not the right framework. And I think over the years, the 60 years or so since that was developed, it's been recognized that people are often operating at all levels at all times, even in times of great stress. And here, when we think about some of these and the need to have your expertise in the equation of developing a local action plan, being equipped to provide good care, and some of these elements are really not base of the pyramid type request. So, in Hear Me, it's sort of needing to know that the leaders understand some of these specific challenges, things like Dawn was just describing, understanding with nuance what's happening in my life outside the hospital, even as I'm trying to provide great care here. And also, again, that local experts are involved in devising or at least adapting an action plan to the local organization. Your infectious disease doctors, your ICU doctors, we can't just take that playbook from the CDC and not nuance it to the unique characteristics of our community, the patients we serve. And so bringing that in. And I think here we found that these listening sessions that we have continued to hold throughout, have been very powerful for us. Small groups, 7 to 8 folks, confidential, facilitated, and we take that information, we share it broadly with our leadership teams, our executive teams, so that all of us are hearing sort of that frontline experience in a continuous way throughout the pandemic. Many other formats, walk rounds, visiting the hospital. I try to go to the COVID units regularly just to check in on the teams. But our goal is to make folks confident that their voice is part of the discussion. If we go to the protect me element, I think, here, sort of intuitive. This one certainly more acute in many ways in the very early days when PPE shortages were acute. But people needing to know that, look, I signed up to be a healthcare professional. I recognize there are risks, but that doesn't mean my 12-year-old or my elderly parent who I care for at home signed up to be put at risk because I'm a nurse or I'm a physician. So how do we prevent folks or help them have confidence they're not taking the infection home? I think here increasingly there's a new dimension to this, is protecting our people from some of the economic fallout of this challenge is a new dimension many of our organizations are wrestling with in this protect me space. But this is, again, a very tangible way we're demonstrating an organizational commitment to protect our workforce as they confront this illness. If we transition to prepare for me, I think this one struck us very early as a little bit off the radar in the way we had appreciated it early on. As physicians, nurses were being deployed outside their area of expertise. A hospitalist having to become an ICU physician, a nurse who's typically a medical surgical nurse having to care for a patient on a ventilator. That our healthcare professionals leaned into that. They were willing to step forward, do whatever was necessary for their community. Retired physicians coming back to the workforce, despite the fact they're in a high-risk demographic group. But what they needed to have confidence in is that I'm willing to take care of a patient who's outside my expertise, but I need to be able to put my head on the pillow at night and know that that patient received good medical care. And what I can't do is practice outside my area and provide what I feel is substandard care. It sort of shakes the integrity of who I am as a healthcare professional. And so we needed to really create that oversight, structures, backup systems, perhaps even in the simplest sense, transmit a message of we're all dealing with challenges we've never dealt with before. You should never feel you have to make hard decisions alone, and rely on your colleagues at its most fundamental level. But to really help give folks confidence that there was oversight backup, that they could provide good medical care. The support me on the next screen is maybe perhaps the most intuitive of just as we are all working in intense circumstances, more hours, can I do this long term? And what's the fallout for my family? Can I be a good mother in this stressful time for my children at home and still be a good nurse? And so how can we provide some of those tangible things? Many of our hospitals adapted quickly on this front, but providing food or take-home meals, transportation to and from the hospital if folks had extended shifts, lodging near the hospital for folks who had vulnerable loved ones at home who needed to stay away from family during the acute phases, I think were some of these things. On the next slide, there's also the emotional dimension to the support me component. We've all seen the data on insomnia, anxiety, depression, PTSD, and here sort of deploying a multifaceted approach, sort of psychologic first aid of just giving people safe space to share concerns, support one another, be forward-looking, and then have the one-on-one support, either via peer support, your EAP program, mental health care for those in greater need in this support me phase. Transitioning to the care for me slide, I think the point I would make here is the psychological impact of quarantine should not be underestimated. A really powerful systematic review published in The Lancet about 2 months ago looked at the world literature on the impact of quarantine. And I think what was really struck me in that data is that individuals who have to go on quarantine are at increased risk for alcohol problems and depression 3 years after the quarantine interval ends. And so this is another challenge where so many of our healthcare workers have acquired COVID-19. They may not have even had a very severe case, but had to isolate at home. They have risks on the horizon that we know about right now. And we need to be preparing ourselves to support them for what they're going to be dealing with a couple of years down the line. There's some data here that healthcare workers who have to go on quarantine actually have greater emotional distress than those who have to go on quarantine who just acquired infection in the community. And all the repercussions of that we don't know. I think part of it is has an origin in the fact that they, especially if they're not particularly ill, know that their colleagues are walking the point in our ICUs, in our hospitals, that they need help. And here I am at home, unable to help, and I want to be serving. And so this support me domain, I think, is really important of what are we doing for our people when they go on quarantine? And it's not just making sure they're still getting their paycheck. On the next slide, I think I showed the process map that we built at Stanford of a really robust support for these folks. We put all of this under our occupational health program so that any employee who tests positive, we get notified. We actually reach out to them day one. We send them some tangible items to just recognize we see them. We have a professional coach who contacts them, works with them longitudinally throughout the arc of their 2-week quarantine. One of the physicians from our team calls them not from a healthcare perspective, but from a check-in on how are you doing, and then referral to mental health support. We also address any tangible needs. If they or their family members need to be deployed to a hotel, we do that at no charge. We provide meal support, childcare support, a number of things to just help them know that we will take care of them if they develop infection. And lessons learned from this, again, everybody on day one says, I'm fine, really appreciate you calling, but I'll make it through. I just wish I was able to go to the hospital and help my colleagues. It's a very different story by a week later. Almost uniformly, I would say probably 85% of these folks are in a dark place and are needing referral to one of our mental health professionals or a peer supporter, dealing with relationship issues, relationship tension at home, depression, other issues. And so again, I think recognizing that. The next slide is just honor me. I think goes without saying, our people are doing heroic things, and we need to acknowledge that. And one of the most important ways we do that is by meeting these other needs. It's not just a thank you. It's not a medal. It's demonstrating we respect and appreciate those things by our actions. So the leadership slide, the next slide, again, is what sort of holds all these things together, of being present, encouraging our team members, modeling some of the endurance, I guess, if you will, or the self-care along the way, and showing compassion. And the slide titled Grief Leadership, here, again, this is a well-studied area, and important for us as leaders to recognize that what is needed from us evolves over the arc of an emotional trauma like we have been through. And in the early days, being visible, transparent communication, being able to direct people to resources, being calm, empathetic, and so forth. And I think many of us have learned these things, but emphasizing that as we move into this next chapter, it's a different set of leadership skills that people are needing from us now. And one of the things we've really been trying to pay attention to at Stanford, have started to see occasionally, again, is this divisiveness that is a predictable thing that can start to crop up at this chapter of just looking back. We did many things right. We didn't do everything right. And it can kind of be in this sense of, an autopsy of everything that went wrong and blame. And at this phase, we had that time of togetherness, but now sort of people going back to their silos. And that those are the things we need to be looking for as leaders, and sort of acknowledge the frustration, acknowledge the anger, but be forward looking of how can we move forward? How can we address that problem? Give people that sense of hope and togetherness looking forward. So the last couple slides, just this emotional phases of disaster slide, I think is one I have come back to many times over the last several months. And when we look at this, I think we can really appreciate many of the things we went through. I think of our colleagues in New York and what they role modeled for us, our colleagues in Italy, other parts of the world. In the early days, it was heroic, and it was inspiring for all of us. We were in that honeymoon. There was that teams coming together. All silos were broken down. We were just one healthcare workforce worldwide caring for needs. And then we move past that chapter and we go into this disillusionment phase. And even in short time length emotional disasters, that disillusionment phase can be up to a year. And I think the important thing about it is that there are these ups and downs, and the recovery is nonlinear. And so as we feel like we're making progress, and then all of a sudden 2 weeks later, we say, gosh, are we really back to that place we were stuck before? Know that that's a normal experience as a leader, and just work through it. And so I think that nonlinear piece is important. The last slide is the evolving needs. And I guess I'll say, just for myself personally, if I've learned anything through this pandemic, it is just how critical this listening aspect of our response is. And I think when we think about crisis communications, we focus so much about trying to get the information everybody needs out through as many channels as possible so that people have the information they need and are aware. And that is certainly important. But I think most of us as organizations have not devoted equal attention to developing very robust sort of incoming communication part of the communication circle. As I mentioned, we started these listening sessions early in the pandemic. We've now had 37 of them, and they've been so powerful for us and have allowed us to just recognize as things, what the needs were shifted, that we could adapt. So we found that these dimensions of the framework have held up. The relative importance of them has shifted at different phases, and that the dimensions within them, again, I hope we'll talk a little bit about childcare in our Q&A session. But, for example, what people really need under Support Me has evolved, right theme, but a different need. And so I think that's probably one of the other lessons, the most important, if I'd encourage folks, of find channels to really let people share their input and needs so that you can respond to them.
This is so incredibly helpful, Tate. You're already getting lots of questions in the chat. One of the questions I hear a lot from leaders is, what do you do with what you've listened? You've done the active step of going out there and having what matters conversations or rounding or creating the space. Now what? And especially if they're bringing up things like staffing or things that feel more like boulders in their shoes than pebbles. How do you manage that as a leader?
Yeah, I think a couple thoughts. It's a great question. The usual intuitive things that the person who asked the question knows, but being able to reflect what the request is, right? That it's recognized, it's needed, and that again, if you're not in a position or don't have the authority to honor that request, that you will take that to the right place and see what's possible. I think people understand that not everything they ask for is possible. And so as we've transmitted through our own chiefs, chairs, leaders across Stanford, I think don't let the fact that you don't have or won't be able to solve all the problems they bring to you prevent you from asking the open-ended question of what do you need? Because we want to transmit to our people that we will try to consider all suggestions, all ideas. We may or may not be able to meet all of them, but we want to hear them. And that then we do have to prioritize so that we kind of are able to transmit back to folks. That's a common request. We're hearing it a lot. We can't solve it in our unit, but it's been heard across multiple units, and we're coming together as a hospital system to think about what can we do. And again, I think oftentimes, and I don't mean to minimize this, but our thinking as healthcare professionals is that more person power is always the solution when we feel overworked. And that is one of many solutions to address feeling overworked. And there are different ways that we can sometimes shed unnecessary work, operate differently as teams, think about what work can be delayed, structure many different other things. Sometimes just people need breaks. They need rest. We need to, find ways to say we are going to have to work hard with this workforce, but we're going to find ways to get everybody a couple days off despite the limited workforce. So I think thinking creatively also. But I would most encourage don't let the fact that you unequivocally will not be able to solve all the problems prevent you from asking and letting people just bring it all to you.
Yeah. There's a lot of fear there in even asking. So that I think that's an important point to note. There's another
can we ask, I would love Dawn's wisdom on that question too, because this is something Dawn has great wisdom on, and I would love to hear Dawn's thoughts also.
It's hard to add to what you've laid out, Tate. It's been such a comprehensive framework. I have a question rather than a response, which is, can you describe how your leadership team has organized its daily work process around this framework? Just take us through a day. What's it like to be there as a leader, and how are you making this real in the leadership processes?
Yeah, it's a good question. So I think, as many organizations, one of the positive things coming out of the pandemic is how much more integrated and cohesive our leadership team has become. Like many, we have our hospital incident command system that meets regularly. And we also have in our traditional academic medical center structure, what were daily calls 7 days a week for the first several months. Then Monday through Friday, now Monday, Wednesday, Friday, of the dean, the school leaders, the hospital executives, and all of our department chairs come together at those time points. And I think that that has allowed us to think about how do we operationalize the whole framework, because different members of our leadership team really champion different elements of this. So, the hear me component, there is part of that is a need for communication and listening. And so we've had our communications team, our senior leaders out doing those things. The protect me piece, some of our, infection control leaders, our logistical team who secures our personal protective equipment, are part of that. These different elements. So our HR leaders helped build out some of the support for people on quarantine. Our operational leaders helped, go out and get contracts with local hotels and, coordinate the meal planning for our people. And so I think what's been really interesting to me is, although for us, this framework emerged out of an effort in our WellMD Center, we partnered with HR. That immediately became the framework for our whole operational effort as an organization, including, things like the communications team, the logistical team, the HR team. And so that, for me, was what was notable is it gave us a cohesive approach to understand a little bit how these different pieces all fit together. And so I guess that's a bit of a high level answer. I will say the one other thing is that we've tried to, as I mentioned, continue to bring some of these learning. Who in your center is going to be the listening group? Who is going to own that? And it's really important to think about it, because obviously as individual work unit leaders, we want to be doing that for our people. But somebody's got to put together that collective voice so that the higher levels of the organization are sort of able to identify those 3 or 4 key things that are really impacting our people now, and that we can develop a system level response to that need. And so who's going to own that? And I think by sort of default, because we jumped in there at the beginning as the WellMD Center, we have sort of owned that for Stanford. And what I think has been really helpful is what I mentioned earlier, is being able to then take those, even the transcripts of these, but synthesize the key thoughts, take these out to the other leaders. And even I'll just say, a week ago on the morning leadership call I was mentioning, we just synthesized, in the last series of calls, we had asked folks, what have you been hearing from your leaders that has been helpful for you as we're in this current chapter, this new chapter? And then we also asked, what have you been wanting to hear that you have not heard from your leaders? And we were able to collate that, and then I just presented that, humbly to our chairs and other leaders of, here's some things people are hearing that are really helpful, and you might want to calibrate. Have you sent these messages recently in your own communications in your unit? And if not, look at which you might want to incorporate. And then here are the things folks have said they have not heard that they are looking for. Or in many cases, they said, we really heard this early. Our leaders were so great at sending some of these messages over the first couple months, but we haven't heard it for 3 months now. And it seems like they're no longer in touch with that. And so helping leaders remember of some of these messages we have to stay on. Yeah. And so I think, can we think about some of those type of challenges as an aggregate leadership team, not every leader having to invent this for themselves?
Yeah, and it sounds like it's funny, you're anticipating questions that are coming up and you're answering them in real time. But it sounds like there wasn't that this is my thing, our team does this. It was a lot of coming together as a leadership team, let's all solve this together, which you hear a lot of, kind of not flattening of a hierarchy, but a lot more cohesion, a lot more support for one another. And I imagine that's something you'll be thinking about trying to preserve post-pandemic.
Jess, can I ask one quick question while we've got Tate?
Yeah.
Tate, there's sort of an odd question. You are an oncologist, I believe, with a
Yes.
specialty in chronic lymphocytic leukemia. Tell us about the maintenance of your energy and the organization's focus on non-COVID patients. Has that been something you've taken a look at? Because your patients didn't go away; they're still there, and they need a lot of help, I assume.
Yes. Yeah, no, absolutely. I think, like many, we have had these ups and downs around that. And in the early days, we went, like most, from 2% video visits to, I think, somewhere around 80% video visits within 2 weeks. And we are now back to about 40%, which we actually are feeling is about the right number. I know many have gone much lower. We're finding that that's a really effective vehicle for many of our patients. It's what they want, and it meets the medical need very effectively. But so we did a lot of virtual care. We were fortunate that our pathology department developed, I think ended up being the first FDA approved local medical center COVID test in about the first 2 weeks. So Stanford had very robust testing capacity early on, and that allowed us to both screen our entire workforce basically, but also have a robust way in which we screened patients coming in. And that allowed us, I think, to open up quickly to provide resume some of that chronic care. But I think the other dimension that it illustrates, Don, is that the timing of when the sort of crucible has been for different healthcare professionals is quite diverse. Our hospital, ICU, pathology, infectious disease physicians felt it right away. If you were in an area where everybody got pulled into those activities, New York, everybody felt it right away. Much of the rest of the country, what was happening in those times was canceling elective surgeries, and that hospital volumes were low and people were at home and they were furloughed. And then either the second wave or addressing that delayed care really ramped up. So for our anesthesiologists and surgeons at Stanford, it wasn't, March, April, and May that were difficult. It was June, July, and August. And for many practices, obviously the economic fallout, if you're in a small practice, having to lay off, team members. And so I think we're now in this chronic phase, as you talked about, but I think when was the really difficult time for outpatient-based, workers or oncologists or, nephrologists? I think, sort of the pressure hit at different time points.
Yeah. Yeah, we're seeing a lot of that. So I actually have kind of a personal question for you. For many of us who are interested in this topic of well-being with an improvement science lens, our focus has been on systems approaches and changes that need to happen organizationally to support kind of workload demand and control issues contributing to burnout. But lately, and you've talked about this, we're increasingly hearing kind of tragic stories of clinician suicide and increasing rates of depression. And it's making a case to shift our focus a bit to better understand and address the factors related to mental health as well. And I think you've already kind of said this has been exacerbated by the pandemic, but I'm wondering what needs to change about the way we approach well-being in light of COVID and some of the up to 3 years, as you stated, mental health sequelae.
It's a great question, Jess. I'll tell you just kind of my way of thinking about it. When we think about sort of that chronic need, my view is you have to have a very good safety net, because no matter how effective our systems are and how much of an organizational culture we wrap around this, there are always going to be some individuals who experience a crisis, whether it's depression, it's a medical error that happened, that they are wrestling with the challenges of it, something in their personal life. We're always going to have that, and we must have a robust safety net for those experiencing that crisis, even as we try to say, let's create an environment where there are as few folks needing the safety net as possible. In the pandemic, and maybe the last introductory, when we think about our Stanford framework, we have that three-legged stool, if you will, trying to cultivate professional fulfillment, and we have to attend to personal resilience, yes, but also an optimal practice environment and an organizational culture that is characterized by leadership, flexibility, giving people voice, giving them input, community, self-compassion that cultivates that. 6 months ago, a year ago, I think we were, all in our focus on the efficiency of practice and the organizational culture domains, and less focused on the personal resilience domain, not because it's not important, but because we have very good data that healthcare workers are already resilient people. As we've moved into the pandemic and we've seen the high rates of depression, anxiety, PTSD, what we're dealing with now is different than just occupational burnout. We're dealing with mental health disorders and distress. And so I think that's been a big shift. And the question it has revealed is, how effective is your safety net? Is it robust enough? And I think for many organizations, they've had to strengthen that. And so it is a very different emphasis right now. I do think it's going to switch back. We'll go back. But right now, it's revealing how important that safety net is. And I think encouraging many of us to strengthen it relative to what our safety nets were before.
Yeah, and augment with some of the things you've talked about, like peer support and buddy systems, so that in this acute phase, at least, folks are kind of stepping up and providing more of that. Thank you for that.
I'll maybe just interject one thing here, and I give credit to two of my colleagues at Yale, Christine Olston and Steve Southwick, who's been an expert in the study, a psychologist study of resilience for many decades, but have been also bringing up this concept of post-traumatic growth. And I think that there's been a strong field there scientifically for several decades, looking at how individuals find ways to, once the acute phases of a trauma are behind them, to both find meaning and consider new opportunities and better ways of doing things. And there's early evidence that this is true this can be true of organizations as well. And so as we think about how do we now, in this moment, also begin as organizations to identify what we've learned from this and where we have become better, where we have broken down silos, where we have advanced teamwork, and where we've maybe served our communities better in some ways than in our traditional mindset, if we were perhaps only thinking through a economic lens in our community. During this time, those things have just been stripped away. It's just providing medical care for our community in the way that's going to serve them best. And so this is also a moment for us to reflect and to think about, as you said, we've learned some things that probably we would not have otherwise learned, and can help us be better, both individual healthcare providers and organizations moving forward.
Yeah. And this is a theme I can't ignore that's come up in the chat. Don brought it up in the beginning. A few individuals noted a difference in response based on profession. There's also a question here from Stephanie about low-wage healthcare workers. How do you think that leadership will start to address some of the inequity across their systems? Can this help them become more generous or philanthropic with their team members? What are some of the ways you think leaders should and could be addressing inequity?
Yeah, it's a beautiful question. And I think in some ways it dovetails perfectly from that last point of, would we have been asking that question a year ago? I don't know that we would. And I think the ability effect of the pandemic to help us understand, or at least see, how important all members of our team as a healthcare system is important. Some of the folks who have the highest rates of infection are the housekeepers in our hospital, our food service people. And so, again, they're putting themselves in harm's way just as much as our nurses and our physicians and others. I'll say that, in a positive way, and this is something that I give great credit to the dean, the CEOs at Stanford, and our chief HR officers. When Stanford put out our benefits, when we provided, in-home childcare it was for the entire workforce. It was the entire workforce, and Stanford leaned into a lot of these things that as these benefits were being stood up, when we provide that robust support for people who test positive, it's not just the physicians, it's not just the nurses, it's the housekeeper as well. And so I think we need to think about, again, a lesson learned in this time. Why is that not always the case for the way we operate in some of these, the way we treat our people? And so I hope we don't lose that. And I certainly don't have all the answers to that question. It's a really important question. And it's one I think we need to sit with and really reflect on, that the pandemic has forced us to confront.
Yeah. Any thoughts from you, Don?
I think the thing I keep coming back to is the change management side of this. You've really had to change the way you're leading, you're investing, the whole workforce, and I'm curious about the management of that level of change at an organization of the gravitas and the history and the size of Stanford. I mean, has it been automatic, or you guys must have? You must have tried to really be explicit about the degree in which you're going to change who you are and what you are. This is phenomenally big cultural shift.
It really has been done, and it sounds perhaps too trite, but I really give credit to that to our Dean Lloyd Minor, our two CEOs, Paul King at the Children's Hospital, David Entwistle at our adult hospital. Their leadership through this and ability to, I think, just bring everyone together and in a very regular way. I think some of it, many of us have had this coming together, but just to create this consistency. I remember when one of the very early days when we started having these more regular meetings. They were every day at 7 a.m., 7 days a week for weeks on end. And it was a little bit exhausting, even though we all knew that it was important work. We were all having 18-hour days, and here you are in these meetings every morning. And I remember our chair of psychiatry, Laura Roberts, when things had started to die down a little bit in intensity, and Laura actually said, it's really important that we keep having these meetings every day for all of us to stay unified as we move into this next chapter. And I just thought it was a very wise insight from Laura. And I think there were just a variety of folks that I don't know how much of it was grand design as it was learning along the way and openness across these leaders, and some wise voices to see what was happening and to recognize that something important was happening in some of these different spontaneous things that evolved, and then to take advantage of that and double down on some of the things that seem to really be helping us in our effectiveness, rather than miss the moment of what was recognizing what was happening and not strengthening it. But it's, as you said, it's one of those things that's been remarkable to watch, and credit to so many different folks who I think have created the ethos that has made it happen.
Yeah, go ahead.
How did the issues of finance and money arise here? I mean, the organization was probably losing a lot. Was that on the table, or did you put it in the back seat? How did that?
I would say it was always visible, but never in a prioritized in any significant way. Again, I remember in the early days when we were in early March looking at New York, preparing for what we anticipated was going to be with us within a week, and just saying we need to double the number of ICU beds that we have capacity for. Even though we opened a new hospital 6 months ago, we had already dramatically expanded our capacity by chance as a system, and just watching, 8-figure checks being written on the spot. Just, we have no money for this. The community needs it. We need to double our ICU beds. Go. It's going to take us 2 weeks to do it. Go. Like many organizations of our size, we lost hundreds of millions of dollars in the first several months of this. That never dissuaded from providing childcare for our people, from doing some of these things that were what our people needed. And so I think as we've now had to move into this next chapter of sort of reopening the practice, looking more toward the future as our numbers have been coming down, we're having to look at that. We've been fortunate. We have not had to lay anyone off. We have not had to furlough people. But many organizations have had no choice but to consider some of those types of decisions. But I guess I would say there was always awareness that we have to be stewards of what we're given, because we need to serve this community long term, not just for the next 3 months. But that was never a priority in the last 3 to 4 months as we faced this acute challenge.
That is incredible. And what I'm seeing in the chat is that not every organization has responded like Stanford. So as we start to wrap up, do you have any suggestions for folks who are working in an organization that maybe isn't as proactive or supportive? What's the next thing they should do to take care of themselves or others?
So maybe I'll ripple up 3 levels: individual, you and your team, and then the leader of that team. I think as an individual, the one thing I would say is, and again, I don't mean this in a trite way, but I think there has never been a time when self-compassion is more important than now. And this is a field of study. Colleague Mickey Trockle here on my team has been really leading the charge on studying self-compassion in healthcare workers, and has shown this distribution among physicians and compared physicians to the general U.S. working population. And this is one area where we have to look in the mirror and say, we are more resilient than workers in other fields, but we have less self-compassion than workers in other fields. We tend to be harsh and self-critical. And the reason I start there at the individual level is I think, well, when I look at the childcare challenge our physicians, our nurses, our healthcare team is confronting, what I hear is 2 dimensions to it. There's a dimension of, tangibly, I've got to try to help provide, homeschool in a sense of oversight, and I'm delivering telehealth in the next room, and it's really hard. But there's another dimension too of people holding themselves to sort of unrealistic expectations of, you cannot make up for everything your kid is not getting right now in today's world. And you have to let that go because you don't control it. And the most important things your kids need from you right now are not solving that algebra problem. They need the empathy, the compassion, the optimism, the calm. And so giving yourself some compassion on the home front as you're trying to do everything and make up for these deficits, let some of that go, focus on the important things there. I think the team level, continue to look out for each other. We've been confronting in our own team of just remember, people are stressed. Give each other the benefit of the doubt. Show each other patience. Offer to help one another. When your colleague is a bit more reactive than they normally would, be more patient. Give them the benefit of the doubt in this time, and continue to encourage each other. I think we've been trying to, as a team, say, as people are isolated, sheltering in place, disconnected from their network. Their work family is more important than ever in relying on this work family for support, maybe more so than they would have in the past. And so harness that. And then as leaders, again, of even local units, say operate at the level you can. You know, for many organizations, the CEO isn't yet all in on some of these things. You may be one of a few leaders amongst the 100 in your organization who's really prioritizing this right now. And don't be discouraged by that, because I still believe that the single most important force for a care team is the leader of that care team. It's not the CEO, it's not the dean, it's not the CMO. It's the local work unit, the nurse manager, the local leader. That person, to the extent they can operationalize these things, be available for their team, model some of these good components of grief leadership we touched on for their team, will do more for the morale and encouragement and esprit de corps within that team than most of what the CEO is going to do.
Thank you so much for that, Tate. And for folks who have been deputized, or their organizations are responding and appointing them to lead. And if you're looking for a little support to do that, Tate has led for a number of years now a Chief Wellness Officer course at Stanford, which folks should check out to get some curriculum behind that. Don, anything you want?
I'll put in a plug.
Yeah.
We're hoping, and it'll probably be early next year. You know, that course we've really designed for folks really at a high leadership
C-suite
level, but we have recognized, had a lot of requests of, can you put something together for more of a work unit level leader, a department level champion, and some skills of implementing things at that level. So we're far along in putting together a course. It'll probably be virtual for those who say, can you help build some skill? And we have had a benefactor lean into that and want to make that available to people around the world. So it'll probably be no cost. And so hope to be able to have some offering on that front early 2021. So maybe folks can watch our WellMD Center website, and that should be coming soon.
Absolutely. Let us know too, and we can get the word out beyond just this conversation today. We only have a couple minutes left, but Don, any last in maybe 30 seconds or a minute words or reflections?
Mainly thanks to Tate, this kind of leadership, and what I want to comment on the intellectual discipline and the way that Tate and his colleagues have approached this to come up with a kind of an evidence-based framework. This is not just guesswork. They're actually gathering the data, they're listening. And this resonates so strongly with IHI's whole theme from Maureen Bisignano and Susan Edgman-Levitan and Mike Berry on what matters to you. Notice how much Tate and his colleagues have actually gone to ground to figure out what really matters to the people who are trying so hard to get through this very, very difficult period. And I guess I have to comment on the compassion here, that you listen to Tate, you imagine what those meetings are like, and this seems to be an organization that truly cares about the people in it. And you'll never get better care from a workforce that isn't cared for itself. So I just want to thank and congratulate Tate, and look forward to further lessons from you.
Thanks, Don. Appreciate it. Great to be with you all today.
So we've reached the end of our time together today. Thank you, Don and Tate. Thank you to Julia Nagy and Vicki Minden, Matt Morris, for your help with today's program. Thank you, audience. There's a lot of accolades in the chat here, but the time you've all taken to participate in this program, we appreciate it. You've made the discussion what it is, and we want to continue to help meet that need. So please be on the lookout for the archived edition of today's show. We'll post it to ihi.org. And again, this is the archives of all of these webinars are on that ihi.org/caregivers site. We're also working on a toolkit and resources to supplement the series, so stay tuned, and we'll post that to that same website. Of course, it's not the only way you can engage with IHI on this topic. Joy in work and well-being continues to be a priority for IHI, and we offer a variety of ways you can continue to connect. Vicki's chatting in for us here a link. You can learn more at ihi.org/joyinwork. Wishing everyone joy and well-being in your work from the Institute for Healthcare Improvement. I'm Jessica Perlow. Thank you.